I can see. So before this break is Dr. Sebastian Lavanderos, who is a department chief in Hospital de Loncoche in Chile. He's going to speak on sociodemographic profile and factors associated with emergency contraception counseling, and which is in Chile. Thank you.
Thank you very much. Good afternoon, everybody. My name is Sebastian Lavanderos, and I'm very delighted to be here. I want to thank the organization for inviting me. This is a paper I'm going to present, published last year on the Revista Médica de Chile, called Sociodemographic Profile and Factors Associated with Emergency Contraception Consultations in Chile from 2008 to 2013. First of all, I have nothing to disclose, and to introduce you the paper, we'll start with the definition of emergency contraception by the World Health Organization. It defines it as the contraceptive methods that can be used immediately after intercourse to prevent pregnancy. What are the emergency contraception indications? According to the same organization, first, when no contraceptive method has been used. Second, when failure has occurred on the used contraceptive method, for example, the breakage of a condom, or it has been used in an incorrect manner. And lately, when a woman has been sexually assaulted and she was not protected by an effective contraceptive method. What are the emergency contraceptive methods available in the world? First, the one-or-just-drug pills and their dose and reported efficacy. The use per regimen using estrogen plus progesterone, typical contraceptive pills, the mifepristone, the copper IUD, and ulipristal. The one-or-just-drug pills have no medical contraindications, that's why those are preferred over the world. The copper IUD has the same contraindications as routine use and has fertilization effects. And mifepristone and ulipristal mainly delay or inhibit ovulation, that's how they work, but they may have anti-implantation, spermatic or fallopian tube effects. That's what evidence has shown. The emergency contraceptive methods available in my country, in Chile, are the copper IUD and the hormonal ones in its special emergency contraception formulation, and also the USP method. There is no register of mifepristone or ulipristal. They are not registered in Chile, and they are illegal because abortion is illegal in Chile. So there is something very interesting regarding to emergency contraception delivery that I have to tell you. Almost all contraceptive methods are delivered by the national public health system in primary care. Primary care gives coverage to almost 80% of population. So before 2010, the delivery of emergency contraception was a discretional decision taken primarily by mayors who administer the primary healthcare systems. And the indication was only made by physicians. Legal changes took place in January 2010, and delivery of emergency contraception was changed to mandatory in the whole public health system. Also, we authorized midwives to deliver emergency contraception and regular contraception as well. And lately, on September 2015, levonorgestrel as the emergency contraceptive form, called in Chile Postinor or Escapel, has been authorized to be sold as an over-the-counter medication. So now any woman can go to a pharmacy and buy this. The current status of emergency contraception, there are few studies regarding to this topic in Chile. There's first a study made by Universidad Central in 2011 that surveyed by found the readiness to deliver emergency contraception by the municipal primary healthcare system. And they found an upward trend on this since 2008 to 2011. There's also a Ministry of Health report, MISAL, on 2013 that found an increase in emergency contraception consultations between 2010 and 2012. By the lack of studies, our study objective was first to evaluate the evolution of emergency contraception consultations at a communal level in the Chilean public health system in relation to the legal changes that took place on the last years, and also to analyze its association to socioeconomic, demographic, and municipal healthcare system characteristics. How did we do this? First, it was a longitudinal and retrospective study based on the REM databases from the Ministry of Health, of which we calculated two rates: first, an ambulatory consultations rate on the primary healthcare system, and secondly, a total consultations rate, adding consultations in emergency departments and also consultations by rate with emergency contraception delivery. From the National Institute of Statistics, we got the female population projections, and from the National Information System for Municipalities, we got the demographic, socioeconomic, budget, and resource availability characteristics. And we link them through panel data regression models. Now I'm going to show you our results. First, what we saw on the emergency consultations rate, we saw that total emergency contraception consultations rate and also the ambulatory consultations rate both raised during the period. Now, when we separate the emergency contraception consultations rate at an ambulatory level between age groups, 10 to 19 and 20 to 44 years old, we see that they both behave similarly. So, all increased progressively during the period. We observed a similar behavior in the ambulatory consultations and by age groups. But we see from 2009 to 2010 an 11.5 times increase in the 10 to 19 years old group, and only a 0.3 times increase in the 20 to 44 years old. Regarding to the percentage of communes with emergency contraception consultations, we also observe an upward trend, and 2009 to 2010 there was observed an explosive increase. When we analyze the consultations by the attending professional, we see that in 2010 midwives were authorized to deliver and indicate emergency contraception, reaching in 2011 an 82.8% of consultations. That later tends to be equal with physicians. When we analyze the median and interquartile range of total emergency contraception consultations, we see that first regions 10th, 14th, and 1st presented the greater rates. In black there is the median, and in white there is the interquartile range. Regions 10th, 1st, and 9th presented the greater dispersion, the greater interquartile ranges. And the 4th region presented the lower dispersion between communes with a low regional median rate. Now I'm going to show you the panel data models. This is the panel data model for the ambulatory emergency consultations rate. I know it's hard to look at, so we'll analyze this. First, we found negative significant associations to poverty, the centers rate, the medical consultations rate, and also the physicians rate in the primary healthcare system. And we found direct associations to schooling years, some regions, the municipal health coverage, healthcare expenditure, and expenditure on staff on the primary healthcare system. When we did analyze the total emergency contraceptions rate, there's something that happens. Poverty remains at a negative association that is significant in almost all models. The other things we analyzed on the ladder lose significance. And also, some regions showed a direct significant association. So, what does our study tell us? First, the effects of the legal changes that took place in 2010. The explosive increase occurred in this year reveals a hidden demand for emergency contraception that was not being satisfied in our country. By one part, obligatoriness and delivery may counter the mayor's ideology and the refuse to deliver emergency contraception. And this would explain the bigger increase saw in the 10 to 19 years old age group. Also, besides, these legal changes were oriented to favor delivery, a high dispersion persisted at the regional and communal level. And regarding to the consultations by attending professional, from 2012, we began reporting consultations in emergency department and by rape, which are attended by physicians. That may explain why they get equal. So, this is important. The socioeconomic level may determine access to fertility regulation policies, as we show with the inverse association to poverty and the direct association to communal scholarship. Also, when we do analyze total consultations, only the association significant to poverty persists, and this may condition access to consultations related to sexual violence. Now, when we did analyze the municipal primary healthcare system factors, we see that when we control by poverty, a better coverage, a better healthcare expenditure per register, and also a bigger expenditure on staff have more emergency contraception consultations, which may show the contribution of municipal resources on the emergency contraception population demand. Also, the inverse relation found on the centers rate and the physicians rate show that these don't constitute limiting factors for delivery of emergency contraception. When we did analyze the municipal healthcare primary healthcare system factors on total emergency contraception consultations, we see that the reactions found are maintained, but they lose significance. So why does this occur? Maybe because consultations on emergency departments, on which rape is included, every rape has to be evaluated in a public emergency department, may be realized by anyone on any healthcare system. So we lose the socio-demographic profile of the population in charge of and health resource of municipalities. Also, there is something very interesting, the inverse relation to the medical consultations rate. There is some evidence that associates more visits to healthcare providers with better health indicators. So this may be an opportunity to educate on self-care and access to healthcare and what do we offer as health professionals. So a greater consultations rate might impact on a lesser emergency contraception consultations request rate, because family planning and self-care promote an effective use of contraception rather than emergency methods. To end my presentation, the limits of this study that are consultations on private healthcare system. We couldn't include this because they do not report these statistics. But as the public healthcare system gives coverage to nearly 80% of the Chilean population, this does not affect our results. Thank you very much for your attention.
Do you have any questions?